Good morning, everyone. Thank you, organizers, for giving me this opportunity. The topic allotted to me is long-term survival and competing risk of death in the ESPATUE randomized phase 3 trial in stage 3 non-small cell lung cancer. So, briefly, before going further, I'll brief about the ESPATUE phase 3 trial, which was published in the Journal of Clinical Oncology in December 2015. So, based on the previous phase 2 pilot induction protocol with 3 cycles of cisplatin and pacli and concurrent CTRT with 45 gray hyperfractionated accelerated radiotherapy followed by surgery that demonstrated encouraging long-term survival in patients with stage 3A disease and also in selected patients with stage 3B disease. So in ESPATUE phase 3, surgery was compared with definitive chemoradiotherapy in resectable stage 3 disease after induction. So induction chemotherapy, it consisted of 3 cycles of 50 mg per meter squares of cisplatin, day 1 and day 8, and paclitaxel 175 milligram per meter square on day 1 in a 21-day cycle. And neoadjuvant radiotherapy was delivered to a total cumulative dose of 45 gray as 1.5 gray fractions per day, given 5 days a week. Concurrent chemotherapy consisted of 1 cycle of cisplatin and vinorelbine, cisplatin 50 mg per meter square on day 2 and day 9, and vinorelbine 20 milligram per meter square on day 2 and day 9 of neoadjuvant RT. And definitive boost RT was given at 2 gray per fraction, 5 fractions per week, to a cumulative dose of 20 to 26 gray without a treatment break from the neoadjuvant RT. And patients were reassessed during the last week of the concurrent CTRT. Those patients whose tumors were evaluated and deemed resectable in the last week of RT were randomly assigned to receive a chemoradio boost that was risk adapted to between 65 and 71 gray in arm A, or to undergo surgery, that was arm B, and the primary endpoint was overall survival. After 246 of 500 planned patients were enrolled, the trial was closed after the second scheduled interim analysis because of the slow accrual at the end of the funding, which left the study underpowered relative to its primary end point. So these were the patient demographics. 171 patients had stage 3B disease and 75 patients had stage 3A disease. And out of the total number of 161 patients, 80 patients were allocated to the chemo-radio arm, that was the arm A, and 81 patients were allocated to the surgery arm. The toxicity maximum, as we can see, was grade 3 in both the arms and even in the surgical arms. So 5-year overall survival in arm A was 40% and was 44% in the arm B. The 5-year progression-free survival rate in the chemo-radio arm was 35% and 32% in arm B. So the 5-year overall survival for all 246 initially recruited patients for entry onto this trial was 34.1%. So this 5-year overall survival data in randomly assigned patients with resectable stage 3 non-small cell lung cancer were excellent in both the treatments, and both are acceptable strategies for this good prognosis group. And they could not substantiate a benefit in the 5-year OS rate for surgery versus individually dose-escalated chemoradio after induction chemotherapy and concurrent chemoradiotherapy. And both interventions, they showed acceptable toxicities, which was in line with the data reported. So here was an update which came in the Journal of Thoracic Oncology in September 2022, that increasing number of stage 3 non-small cell lung cancer patients experience long-term survival, and new treatment principles of checkpoint inhibitor immunotherapy has specific impact on long-term survival in all lung cancer stages. Therefore, randomized phase 3 trial data sets looking at optimum local treatments, they need to be reassessed. So randomized phase 3 ESPATUE trial results looking at definitive surgery versus definitive boost radiochemotherapy, as I had already discussed, they are already reported, and now a 5 and 10-year LTS data report competing the risk of deaths for the different treatment strategies are reported. Here, long-term survival based on follow-up until Jan 2022 for all patients still alive, including the recent surveillance follow-up visits, that is updated. The JMP 15.2 was used for all the survival functions. For survival comparison, both arms log rank test was used, and SAS 9.4 were used for computing risk of deaths for the patients follow-up up till Jan 2022. The long-term survival data of both arms were presented with percentages and confidence intervals. From Jan 2004 until Jan 2013, 246 patients were enrolled, as we already seen, in the centers in Germany and Netherlands. Following induction, 166 patients, they were, as we have seen, they were randomized to the chemo boost arm A and surgery arm B. At the last follow-up in Jan 2022, 37 of 246 patients were still alive. Median follow-up of patients still alive was 129 months, and the patients alive in arm A were 15 out of 80 and 16 out of 81 in arm B. The overall survival following randomization, 5 years OS in arm A was 43.8% versus 43.2 in arm B. The 10 years OS in arm A, 28.3 versus 29.9. The PFS following randomization, 5 years PFS in arm A was 30 months, 30% versus 29.2, whereas 10 years progression-free survival was in arm A 23.3 versus 19.8. So the long-term survival rates in stage 3 show encouraging 5 years overall survival and 10 years overall survival and PFS results, and no significant differences between the surgery and the radio chemo arm as definitive local treatment, and no clear signals for relevant differences between both arms in the deaths from the first lung cancer, the treatment-related deaths, deaths from the comorbidities, or deaths from the second cancer without lung cancer, and deaths from the second lung cancer. Deaths from the comorbidities and deaths from the second lung cancer turn out to be a major long-term risks of patients in these stages, and these important phase 3 data may serve as baseline information to compare with those in future protocols, including CPI, the immunotherapy, and disease deaths from the second lung cancer may potentially be decreased by prospective lung cancer screening. And deaths from comorbidities was mainly due to the cardiovascular, vascular events, pulmonary events, and infections or septicemia. Thank you.